Hello everyone, good morning, good afternoon and good evening. Today lecture is respiration, applied aspects. First of all, I want to mention that applied respiratory physiology forms a link between the basics of respiration and clinical manifestations of respiratory diseases. This lecture is concerned with some of the important applied aspects of respiration, which include respiratory adjustments to stresses in health, disturbances of respiration, artificial respiration, and cardiopulmonary resuscitation. Respiratory adjustments to stresses in health illustrate the integrated operation of the respiratory regulatory mechanisms. The stresses faced by respiration requiring adjustments in day-to-day life include the following. 1. Respiratory adjustments during exercise. 1. Respiratory adjustments during exercise. Since during exercise many complex adjustments of muscular blood flow, metabolism, respiration, circulation, and temperature are required. 2. Respiratory adjustments at high altitude. When a person is exposed to high altitude, particularly by rapid ascent, the different systems of the body cannot cope with the lowered O2 tension and the effects of hypoxia start. Respiratory adjustments are thus a part of changes in the body at high altitude. Three respiratory adjustments to high atmospheric pressure form a part of the physiological problems faced by the body while going under the sea. Eupnoia refers to the normal respiratory pattern, which implies a normal rate, rhythm, and depth of respiration. Tachypnoea refers to an increase in the rate of respiration. Bradypnoea means decrease in the rate of respiration. Polypnoea is used to denote the rapid but shallow breathing resembling panting in dogs. In this, the rate of respiration is increased but the force does not change significantly. Apnoea refers to the temporary cessation of breathing. Hyperpnoea signifies a marked increase in the pulmonary ventilation due to an increase in rate and/or force of respiration. Hypoventilation term is used to describe a decrease in the rate and force of respiration. Hyperventilation refers to an increase in the rate as well as force of respiration. Dyspnoea. When hyperpnoea involves fourfold to fivefold increase in the pulmonary ventilation, an unpleasant sensation or discomfort is felt. This type of respiration is called dyspnoea. Periodic breathing refers to a respiratory pattern characterized by alternate periods of respiratory activity and apnoea. Some of the abnormal respiratory patterns are discussed in detail. Apnoea refers to a temporary cessation of breathing. Depending upon the cause, apnoea may be of following types. 1. Voluntary apnoea refers to a temporary arrest of breathing due to the voluntary control of respiration. It is also called breath holding. 2. Apnoea after hyperventilation occurs due to the reduced stimulation of respiratory center owing to CO2 wash caused by hyperventilation. 3. Deglutition apnoea occurs reflexly during swallowing, about 0.5 s. During pharyngeal stage of swallowing, the fluid or food stimulates the sensory nerve endings, 5th, 9th, and 10th cranial nerves, around the pharynx. The Cheney-Stokes respiration is a periodic type of breathing in which the alternate periods of respiratory activity and apnoea occur at regular intervals, and during the period of respiratory activity there is waxing and waning of tidal volume. The term hypoxia is used to denote deficiency of oxygen supply at the tissue level. Hypoxia can occur because of any one or more of the following defects: decreased oxygen tension, PO2, of the arterial blood, decreased oxygen carrying capacity of the blood, decreased rate of blood flow to the tissue, and decreased utilization of oxygen by the tissue cells. Signs of hypoxia are: 1. Cyanosis is the bluish discoloration of skin and mucous membrane caused by the presence of more than 5 g of deoxyhemoglobin/100 ml of the capillary blood. Peripheral cyanosis is seen in the nail beds and is suggestive of stagnant hypoxia. This is because perfusion in these distally located areas is worst affected in hypotensive states. Large amount of O2 is extracted from the hemoglobin and the concentration of deoxyhemoglobin rises to produce cyanosis. Central cyanosis is seen in the earlobes where skin is thin and in the mucous membrane of lips and tongue. These areas receive good blood supply and become cyanotic only if the O2 saturation of blood is low, as occurs in the hypoxic hypoxia. Other signs of hypoxia are: tachycardia. It occurs as a peripheral chemoreceptor reflex response to the low arterial oxygen tension. And tachypnoea, presence in the hypoxic hypoxia where arterial PO2 is low, but absent in both anemic hypoxia and stagnant hypoxia in which the arterial PO2 is normal. Treatment of hypoxia basically includes treatment of underlying cause and oxygen therapy. Oxygen therapy is of great value in certain types of hypoxia and at the same time of almost no value in other types. In general, simple O2 therapy is not of much help in treatment of hypoxia because diffusion across respiratory membrane depends upon the partial pressure of gases. Therefore, alveolar PO2 can be increased by inhalation of 100% pure oxygen or inhalation of 100% pure oxygen at high barometric pressure called hyperbaric oxygen therapy. Hypercapnia refers to an increase in the arterial PCO2, normal value 40 mm Hg. When hypercapnia is the primary problem, it is associated with the respiratory acidosis since an increase in CO2 promptly generates excess H+. Hypercapnia occurs due to the following: 1. Defective elimination of CO2 as occurs in reduced pulmonary ventilation and reduced effective alveolar ventilation. 2. Accidental inhalation of CO2 in persons working in breweries and refrigeration plants. Asphyxia refers to a condition in which hypoxia, decreased PO2, is associated with hypercapnia, increased PCO2. Causes are strangulation, drowning, acute tracheal obstruction, due to entry of food or due to choking, and paralysis of diaphragm as in acute poliomyelitis. Carbon monoxide, CO, is a dangerous gas present in exhaust of gasoline engines, coal mines, gases from deep wells and underground drainage systems. Carbon monoxide produces anemic hypoxia and derangement of cellular metabolic system. The effects of hypoxia produced by decreasing PO2 at high altitude depend upon the level of altitude, the rate at which hypoxia develops, and duration of exposure to hypoxia. Atmospheric pressure of 760 mm Hg at sea level is considered 1 atmospheric pressure. Pressure increases by 1 atm for a depth of every 10 meters 33 feet as one descends beneath the sea. Decrease in volume of gases occurs due to compression as the pressure increases undersea. Deeper and longer dives can be made safe by following preventive measures. 1. Use of breathing apparatus. 2. Use of breathing mixture containing helium and low oxygen concentration. And 3. Slow ascent or use of decompression tank. Artificial respiration, AR, alone is required as an emergency life-saving procedure. When there is sudden stoppage of breathing as seen in drowning, electrocution, anesthetic accidents, carbon monoxide poisoning, strangulation and accidents. Artificial respiration may also be needed when breathing is expected to stop gradually, as in paralysis of muscles in poliomyelitis, diphtheria, and ascending paralysis. Presently, the only manual method employed is mouth-to-mouth breathing, exhaled air ventilation. It can be applied quickly without waiting for the availability of any aid. Mouth-to-mouth method is most effective manual method because the CO2 present in the expired air by the resuscitator can also directly stimulate the respiratory centers and facilitate the onset of respiration. Cardiopulmonary resuscitation, CPR, is required in some patients when heart and respiration both stop. Breathing usually stops before the heart stops, so AR should be started immediately. The following plan, called ABC of CPR, has proved useful in reviving such patients. A. Airway care is required in the unconscious patients. Immediately, tilt head back with the hand under the neck to maintain an open airway. B. Breathing by AR method is required when the patient is not breathing. Mouth-to-mouth respiration should be immediately started. Feel carotid pulse, if present continue AR only. C. Cardiac massage is required when carotid pulse cannot be felt. During external cardiac massage, sternum should be depressed by 4 to 5 centimeters at a rate of 80 to 90 times/min. The cardiac compression should be alternated with mouth-to-mouth respiration at a rate of 1 ventilation to 5 chest compression. Thanks for watching. See you next lecture.